So I'm going to talk about sleep and Parkinson's disease, and then I'm going to, when I talk about the research angle, kind of tie it in with some interesting new thoughts. So I'm going to talk about normal sleep and sleep stages, transition that to sleep and Parkinson's disease, and then some final recommendations. So what sleep scientists have learned, and I am not a sleep scientist, is that we actually need a combination of REM and non-REM sleep. REM is rapid eye movement, REM, where we dream, and then non-REM is the other stages, which I'll show you. But there's a combination of an amount of that really makes for a good night's sleep. And as I was putting this together and have done talks like this before, there's been a huge question in science: why do we sleep? And at first you think, well, we all know why we sleep, but if you think about it, why do we sleep? What is the physiology of sleep? What's happening? And still people are trying to figure that out. I just know that if I sleep well, I feel better the next day, and if I don't feel well, but what the heck is happening? So restorative sleep is something that is really, really critical. So if we look at, I don't see it up there. If we look at normal nighttime sleep stages, you'll see up at the top, and it doesn't look like I have a pointer on the screen. We are actually kind of rotating through stages of sleep from awake. REM sleep is at the top, and then into deeper stages of sleep, and we kind of go up and down, up and down, up and down through the night. And what scientists have determined is that we spend a little bit more time in REM sleep towards the end of the night where we're dreaming. And as you see from the chart here, REM sleep, where we're dreaming, is very close to being awake. Whereas deeper stages of sleep, which happen earlier in the evening, earlier in the night, are when combined with the REM stage sleep is what apparently gives us our best restorative sleep. So that's really the type of sleep stage rotation that we're looking for to achieve sleep benefit. Parkinson's disease and aging and other underlying states can really disrupt sleep. And I wanted to talk through some of the different types of sleep disorders that I see in people that I work with Parkinson's disease, and then offer some of my thoughts on what I do to try to help people. So the handouts that you have are not to take to your doctor and say, I should be doing this, but just some of my thoughts and thoughts for you to work with your own physicians. Anxiety and depression, both very common in Parkinson's disease, higher statistically than in the non-Parkinson's disease age-matched population. And we think part of the symptomatic presentation of Parkinson's disease, not just a reaction to it, can be very upsetting of sleep. People will tell me that they will awaken in the middle of the night and they're kind of ruminating on thoughts, things that they need to do, they're worried about family members, things like that. And that kind of wakes them up, and then they can't fall back to sleep. There are ways to manage that, lots of ways actually to manage that. So if that is part of what's happening with your sleep or while you're awake, please talk with your doctors, because there are lots of ways to manage those symptoms and help you to feel better. And exercise is one of them. We'll keep coming back to exercise, but it is what I tell people is it's the only thing that I arm twist people on for therapy is to exercise. And the other stuff we can fold in if needed. But anxiety, depression really are common and need to be addressed and can be effectively addressed. Wearing off motor symptoms. So off means your medication is not working as well, you're slowing down, stiffening up. Motor is movement. So I'll have a lot of people tell me, if I wake up in the middle of the night, I'm kind of worn off from my medications, and what do we do to adjust in bed? We don't do this. We do kind of a quick, that type of thing, and that's what people with Parkinson's disease are having some difficulty with, to variable degrees. But there are ways with the medications in particular, the deep brain stimulation we talked about, to extend your on, or when the medication is working and when you're feeling more mobile and in control, we have ways to reach that farther and farther overnight. And I'll have people say, if I wake up in the middle of the night, I'm feeling kind of immobile, and then I'm kind of laying there and unable to get back to sleep. There are ways to reach out and get that more mobile. So talk with your doctors about that. Sleep-wake cycle disruption. I was going to say my 20-year-old son has no problems with it, but he's like 2 a.m. to 2 p.m. if he's not in school. So, but this is very, very much disruptive with age and with neurological disorders. What we all have a clock, an internal clock. There's a circadian rhythm that we have that kind of awake, asleep, and then diurnal rhythm is actually driven by the sun, and they kind of coincide a bit. But what we should be doing is, when it's dark, falling asleep, sleeping for however many hours, getting those stages of sleep, having nice restoration, wake up and get ready to go. That's what should be happening. It doesn't always happen, and particularly with Parkinson's disease, that can be an issue. There is a physiology to it. There are parts of the brain that secrete molecules that will help our brainstem to wake up, so we're awake and alert and ready to go. And then at nighttime, tied with the sun going down, our pineal gland will produce melatonin that will get us a little tired and help us to start to move towards sleep. So that's kind of the physiology very quickly of sleep-wake cycle regulation. And there are two types of insomnia related to that I want to talk about. And again, in your slides, so it's not critical that you absorb all this at the moment, but sleep initiation insomnia. So people say, can't fall asleep, but once I'm asleep, I'm fine, but I'll lay there awake. Exercise absolutely can help that to get you kind of energized during the day and we're tired at night. If you can, minimizing daytime napping and maximizing the activity in the evening. People that drink a lot of water, caffeine, alcohol in the evening, sometimes that disrupts the ability to go to sleep. Sometimes people who are using their bedrooms as offices, television. What's that?
I just thought that was funny.
Bedroom for sleep and sex only. That is what I was taught in medical school, and you know, there might be something to it, but I'll let you do whatever you want. But sometimes, but honestly, if you have, this room is for your exercise, this is for relaxation. Sometimes if your bedroom is your office, it's not where I go to sleep and relax. It kind of carries over, so that's where that comes from. But I will let you do whatever you want with that line. We've talked about mood management, and I do use melatonin to try to help with sleep initiation. There's a lot on the internet about how to use this, how not to use it. It's really not very well delineated scientifically. I tend to be a little aggressive with it. I tend to use it long term for a variety of reasons, watching for side effects. And I talk about this with the people that I recommend this to, but it actually can do a nice job to help with sleep initiation and people not being groggy the next day. Sleep maintenance insomnia is more, I wake up in the middle of the night and I'm up. I fall asleep just fine, but I can't get back to sleep. There are extended release, sustained action versions of melatonin that people have told me work. So sometimes we try that as long as it's not overly sedating. And then I have a list of medications that I'm not going to go through here, most of which are useful for anxiety, depression control, but can also make people a little tired. And so when they wake up, instead of being awake and alert, they wake up, they're a little bit groggy, they can run to the bathroom, and then by the time they get back to bed, they're still tired enough to fall back to sleep. So as long as it's not, I'm a zombie all day, they can be helpful. The bottom line, the Benadryls, the benzodiazepine, Xanax, Valium, there are, in ambience, there are some potential side effects that are really tough with those medications, and I'm really not a fan of using them. And I talk individually with people that I work with about why, but I don't think those are ideal approaches. There are too many others that can be effective. 5 minutes? All right, thanks. REM, sleep behavior disorder, REM, rapid eye movement sleep. This is a great picture. People will tell me, for my number one, I don't know about the other docs in the room, number one for me is, or for people that I'm working with, is I'm being chased, attacked, pursued, something's jumping at me. And number two, I'm in some odd version of an old workplace. And I'm kind of there. And when I showed you when I showed you this before, you see that REM sleep, REM, rapid eye movement sleep, those gray boxes there is very close to awake. So you're kind of close to awake, and they can kind of overlap a little bit. So people can actually fight out and yell out in response to the dreams and punch walls, punch bed partners, throw themselves out of bed. If it's mild and not, I see some head shaking, which I often do. This is something we see with Parkinson's disease, and it can be treated. The other thing I comment about is when people are doing this through most of the night, look how close to sleep they are. So if you imagine those gray boxes all the way across, you're not getting very deep sleep and not getting very restorative sleep. So I do work pretty hard with people to try to manage that. I do find that people that take their dopamine medications, particularly immediate release levodopa close to bedtime, are much more prone to REM behavior disorder. And so sometimes just the presence of or just moving the medication a few hours away from bedtime can get that to go away. Extended release near bedtime as opposed to immediate release sometimes does a great job to eliminate that problem. Mirtazapine can help with sleep, but it can also kick up dreams. Melatonin can do a nice job to knock down the dreams and acting out the dreams. Gabapentin plus minus, I might go to it if we're having trouble. But just some thoughts. Those are things that I use to try to help that. Periodic limb movements of sleep, restless legs. I get a little of this from time to time, so I have much more empathy for people that tell me about it, because there are some evenings where I'm like, oh boy, there's a sensation I'm having, it's uncomfortable, I gotta kind of move a little bit to relax. So there are multiple kind of components of this, but this picture kind of pictures how I feel in the evenings sometimes. And that can be very disruptive. It happens often in the evening as you're trying to wind down, and it's hard to fall asleep through this. So again, there are a number of medications that can be helpful for this that I won't go through in detail, but you can talk with your physicians, and I will really use any of these. And I've had people respond pretty well. I don't typically have to go to extremes, although I've recently done some IV iron infusions in 2 people to get this to calm down. That's pretty extreme, but it worked. So any of the docs in the room that want to know how to do that, I've now figured out the process, so let me know. But there are some options here to talk with your docs about if you're having this problem. Snoring, obstructive sleep apnea, me too. I guess it's just the aging process. My wife is no longer with me. She's in another room, so that's how she's treating it. But what you're seeing here is kind of what happens. There's a graph on the bottom of inspiration, expiration, then you stop breathing. And you look at it's kind of scary actually when you look at that cutaway diagram there of the blocked airway. That's actually what's happening. You are obstructing your air passages. When I got my sleep study done, I stopped breathing every minute for the whole night. And I thought I was just middle-aged and working hard. It turns out I was middle-aged, working hard, and not breathing for a few seconds every minute. And when I got that taken care of to keep my airways open, now I'm just middle-aged and working hard. So, it puts strain on the heart. it can lead to heart attack, stroke. There are dangers to it. So when I talk with people about sleep, I ask their bed partner, does he, she snore? Does he, she stop breathing? A lot of times I get yes, and then what? So that is important, and that can actually do a nice job to help. So exercise, sleep hygiene, which I didn't really talk about, except for not drinking a lot in the evenings, sleep, wake, kind of try to keep the times right. The line that the laugh was on about the use of the bedroom, but that can help. Talk with your clinical team. There are things we can do to help you. Sleep evaluation just in case you've got something going on that the neurologist isn't going to be able to help you with. But we usually can find a way to help you sleep better, which translates into kind of feeling better, being able to exercise better, et cetera, et cetera. So I'm done.